Okay, so why we get a health history? It's really important, and we do different forms of health history, like how intense it is or how focused it is. You know, I think I mentioned this before, I think for this class, but if somebody comes to my office and they're there for a sore throat, I'm not going to do an extensive health history or even an extensive physical exam. I'm going to narrow it down. If someone comes to my ER and I'm the ER nurse there, and they're coming in by ambulance, the ambulance calls in and says, we've got, you know, this cardiac patient, they're coming in, the EKG is showing that they've got a STEMI MI, which is a ST elevated MI. It's a very dangerous MI, and that gets you to the cardiac cath lab within an hour for surgery, okay? So I've got less than an hour to get you on the table in the cardiac cath lab. So I'm not gonna waste time to interview you about your occupation, whether you're retired, who you live with at that point and stuff. We'll capture that stuff later when the patient either comes back into recovery or gets admitted up to the floor by the floor nurse, okay? So the amount of information that we seek and we get can vary a little bit depending upon why they're coming in, and also, how emergent it is. Or is it a clinic setting where it's not that emergent at all? So we collect subjective data to combine with objective data from the physical exam and lab studies to form a database. So this SOAP note is really a database, and it's really important. Most of the time you guys are going to be doing it within the electronic health record. You know, you're going to be doing your notes at clinical and stuff in there. So you're not going to be writing it out. But I'm going to tell you right now, if you that computer goes down, you're going to have to be able to write a note, all right? And not only are you going to have to be able to write a note, but you're going to have to, if you go to grad school, and I know a lot of you are like, oh my God, I just got into nursing school and she's talking about grad school. But if down the road you go into grad school, you got to be able to do the physical like we did last week and be able to write it up, and a little bit more extensive type of a physical than that, which we'll do by the end of the semester. But you've got to be able to write up a note, you know, in grad school to be able to document your health history and your interview plus the physical exam, okay? So very important stuff. So it provides a complete picture of the patient's past and present health status. So we really get a lot of information, you'll see as we go through this. And it can be used as a screening tool for detection of abnormalities. So based on the patient's answers or their family member, spouse, cousin, neighbor, whoever comes in with them, you know, a lot of times they contribute to the database that we collect, all right? It's printed or electronic format that's available for review, validation, and updates. And the sequence in terms may vary because of the information we're obtaining, like I said, depending upon why they're there and how fast we have to process them, the content may vary somewhat. And focus may differ in terms of clinical practice setting. What I get in a clinical or a doctor's office is far less than what I would get in the ER. And if you were coming in a trauma, or you were coming in because you were having that STEMI MI, yeah, I'm going to get a lot more information on you. And it's due to the nature of the complaint, okay? So did we talk about subjective versus objective information last week at all? Or did you just read it? All right, so there's subjective and objective information. Last week what we did the objective. The objective is what you see, hear, and feel when you do your physical exam with your own hands, eyes, and ears, okay? So you know it's true because you've witnessed it and you know firsthand what it is, all right? That's objective, objective information. The subjective information could potentially not be as true because we rely on the patient, we rely on family members, spouse, partner, aunt, uncle, cousin, neighbor, whoever has come in with them in order to glean a lot of information. If the patient's unconscious or semi-unconscious or in a condition in the ER where we can't get much information at all from them, we really rely on the family or whoever's brought them in for context about what's passed with medical history, you know, childhood illnesses, if we can get all that information, allergies. You know, in CPR they say if the person regains consciousness or you're able to bring them, you know, back with rescue breathing, that you need to ask them questions right away, like, do you have a history of cardiac history, or has this happened to you before? And what are your allergies? So you get what you can get with the time, okay? You guys are, still fairly young, and your parents are probably still alive, and your grandparents may or may not be alive. But it's real important that if you haven't already, that you ask questions about your family history and get that information from your parents. Because right now you're young and you're healthy, but at some point your health is going to change. And things run in families. They're handed down genetically and through families in forms of disease and such. And so, it's going to get to a point when you start hitting your mid-40s to certainly your mid-50s, where your body's going to be changing, you're getting older, and these things are going to start popping up. And you might develop high blood pressure, and the doctors or the provider is going to want to know, does it run in your family? Or you're going to have cholesterol problems, and they're going to want to know, does anybody in your family have cholesterol problems? So get that information now while you can. I'm embarrassed to say I have 3 kids, and aside from the fact that I've had neck surgery recently, I don't think that any one of them could probably tell you an accurate health history from my side of the family. And I've told them it's just like, one in your ear and out the other. Because they're young, they're healthy, they're not thinking about that. But yet on Monday, I got a call from my oldest daughter, and she's like, does diabetes 1 run in our family? And my head's like, that's odd. I'm like, no, why? And I said, diabetes 2 does. She said, well, Morgan, which is her oldest daughter, my oldest granddaughter that's at college now, she went in for UTI into the doctor, urinary tract infection, and they took a urine sample, and she's spilling sugar into her urine, which is not a good sign, because that could be the beginning of diabetes. And so the long and the short of the story, why I find it hard that if she does have type 1, that we haven't come across that yet in 18 years. Potentially it could. It's a remote chance, but it could. So, now we're going to have to wait a week. They're going to repeat the test and see if the findings are still the same, and then they'll do more tests on her. But, so you need to know these things, okay? And I know on their dad's side, he recently had a stroke, and they know that he's diabetic and he has high blood pressure, but they don't know much about their dad's side or their grandma on that side either. So ask those questions now. So, the health history sequence, we start with biographic data on the patient. We note the source of the history. Is it the patient, or is it someone else that's with them that's providing history information to us? Reason for seeking care, the present health or history of their present illness, what brought them in and when did it start, etc. And we get a lot of information about that. We ask about 7 questions all the time when people come in, okay? And we're going to talk about those 7 questions. The past health, the family history, review of systems, which we'll talk about and I'll explain more as we get going through. And then a functional assessment of the activities of daily living. Activities of daily living are a patient's ability to get up, make their bed, do their AM hygiene, be able to brush your teeth, shower, bathe, etc. The ability to ambulate, the ability to go down into their kitchen and cook a meal. Those are the activities of daily living. And those are real important, because when someone comes in and they're ill, they may not be able to fulfill all their activities of daily living because of what's gone on with them. And we have to try to give them physical therapy. Occupational therapy is with their hands. Physical is more the entire body and more with walking and such, and bending and moving. And speech language therapy, if they're not able to communicate because of a speech issue that's going on, and it may be from a stroke, we're going to try to restore them to that previous state. So we need a baseline of what was their previous state before all this stuff started happening to them, okay? So the health history may differ slightly in terms of the individual patient concerns, particularly with your older folks or people that haven't been to a doctor in a while. People tend to save up everything that's gone wrong with them for at least 6 months to a couple of years, and then when they have that doctor's appointment and you've only scheduled them for 15 minutes, they come up with 23 things that are going on, okay? And so You as a health provider have to kind of narrow down what's the most critical. You think in terms of what's the most life-threatening. So obviously chest pain and shortness of breath are going to trump, lower back pain if they come in. Yeah, we'll deal with the lower back pain later, but the fact that you're having trouble breathing and your heart is an issue right now, that's more important, okay? And legally, if someone tells me something that, let's say they give me a list of 10 things, okay? And I figure out that the heart or the respiratory is like one of the main 2 things that I gotta deal with that day in the office. I can wait to deal with the other, 8 things. But I have to say in my notes that I'm going to review, I've made an appointment for them to come back in a week and we're gonna talk about ABC, whatever we didn't get done and stuff. So if someone tells you something and you decide not to document it because that's not important right then and there, that's a legal issue. So you always have to document it in your notes, and just in your plan, the P part of the SOAP, you're gonna say that you're gonna bring them back at a later date, or you're gonna discuss it with them, at some point in the future, and then make sure you follow through. Because if whatever you didn't discuss with them, if that ends up causing a life-threatening emergency for them or kills them, you're going to be on the hook. I would be on the hook in court if I didn't take care of all the other issues, okay? So even though it's not the most pressing thing, it still has to be dealt with. So never occlude or not include, something that they're telling you in your notes. Make sure you capture everything. And it's painful sometimes, it really is. My youngest daughter is a hypochondriac. And seriously, when I go to the doctors with her, a lot of times she'll take me with her because she has attention deficit. So the doctor starts talking and she hears 2 sentences and then just checks out. And it's like I sit and take all the notes and listen to what they're saying and then kind of explain it to her what's going on. And it's painful. It is so freaking painful because everything they ask her, it's yeah, maybe, yeah, now that you mention it, and it's like, oh my gosh, because they'll go through a whole list of things and she's hitting every single one of them, and it's like, I know it's not true, And then the other thing is the patient's developmental. So obviously what a 5.5-year-old can tell you is different than what an adult can tell you, or an older person with maybe some confusion and dementia. And so you have to consider the source and take into consideration those types of things. And then the presence of their health problems, no detection of any health problems, concerns related to aging. Now, most of the time in healthcare, unless we're in primary care or private practice, we don't really have time, but even then we don't really have time to sit and just chat with people like we used to. And the doctor's office used to serve a social function in people's lives because they all knew each other. I grew up in small towns in upstate New York where we had one doctor. Everybody went to that one doctor, and that poor doctor knew everything about everybody, and if they were feeling down and depressed or glum or anxious about getting older and the changes that were happening in their body, that doctor heard it all because that was their socialization, because they were, particularly older people where they don't have as many people around them anymore. Identification of vulnerable populations. If we can kind of figure out who's at risk based on the information they gave us, or it gives us big clues to maybe what's going on with them right now and why they came, that's really important. And we can identify these vulnerable populations, okay? Identify barriers to communication. So if they have speech language issues, whether it's they speak a different language or whether they've had a stroke and they're having difficulty speaking, we can identify that early on and try to either get an interpreter if it's a language barrier, or we can get a language board for speech language therapy to help communicate the urgent needs and stuff, or figure out how we're going to communicate with that person while they're in and under our care. Now, just because somebody's there and they're with the program doesn't mean they're going to tell you the honest truth about whatever's brought them to the hospital today. Case in point, my dad, when he goes to the ER, and he's done this several times in the past 3 to 4 years, okay, his main objective is to get back home to his elderly wife because he thinks he primarily takes care of her. But in the past year, he really isn't taking care of her anymore. Her son and daughter-in-law are. But they're living there with them. And so my dad will not tell things to the nurses or healthcare providers because he knows, he's smart enough to know that everything he tells them could keep him a day longer or an hour longer in that ER, okay? Or have him admitted to the hospital, which is his worst nightmare because he doesn't want to be admitted to the hospital and not be with his wife, all right? And, you know, both of them are just like unbelievable. Like 3 years ago, Dad had a major gastric bleed. And it started the night before he went to the ER. And his wife, she's not my mother, face, okay? His wife just put a pad underneath him. And here the man is bleeding, okay? Like, ding dong, the bell should be going off, you need an ER visit. But no, they stayed home that night. And so the next morning when he got up out of the chair, everything gushed from his rectum, all right? And then he went to the ER by ambulance because he was about ready to pass out. He lost so much blood. He gets in the ER, they actually have him waiting. He stands up again to do something, and another big gush, and he almost died, okay? So you're not necessarily going to get the full truth or information. I think most people try. Some people honestly forget. I know when I'm going through, sometimes I forget certain little things because, you know, it's been several years now. I've got, you know, I'm not the sickest person in the world, but I've got some chronic health issues and stuff, or things that I might, you know, forget. And so you just keep in mind of what the source is. Try to talk to all the sources available to you with their permission. Because of HIPAA, you have to ask if you can talk to the neighbor, the friend, the cousin, or whatever, and try to get the information. And the neighbor might tell you, well, John's been falling more in the past 6 to 8 months. I've been over to his house a couple times now and had to help pull him up off the floor. Well, that's a concern because John has fallen now and he's maybe fractured his hip. He's in your ER. You're sending him for x-rays. You know, and at some point you're gonna have to send John back home. Well, if John lives alone or is in an unsafe condition at the house because he's been falling all the time related to aging, that's a concern. Maybe we can't send John back home, okay? Or we need to make other arrangements, or we need to make sure he gets rehab to strengthen up his muscles and stuff so that he's not falling if possible, okay? So the biographic data, we get their name, their address, obviously phone number, age, birth date, birthplace, their insurance information, gender identification, relationship status, are they married, single, divorced, widowed, and who is with them now. You know, we document that in the medical record. And then also, who's their support system? Who helps them out at home? Particularly our older folks that we're going to send back home. We want to know their race and ethnic origin, their occupation, usual and present, whether they're retired. We want to kind of know what they did do when they were working because it may have an impact on their health now. We know that a lot of pipe fitters, ship workers, etc. have been exposed to asbestos. So asbestosis is a real health concern on this population. So if we know that somebody was in that job that had an occupational hazard that perhaps may present in a cancerous way or in a non-healthy way down the road, we need to know those things, okay? And we need to know what their primary language is, whether it's English or not, so that we know if we need to provide an interpreter so that we can understand what they're saying when we're doing the full health history and interview. So the source of the history, you record who furnishes the information. Anybody that's there with them, make sure you include them in your note. Usually the person, although the source may be a relative, friend, or neighbor. I work in the free clinic, and some of my patients, we have a lot of Chinese nationals, we have a lot of people from Middle Europe, and we have a lot of people from the Middle East or Northern Africa area. And so a lot of times their community provides a driver to them to drive them to the clinic, but that person really doesn't know anything about them. They're just simply the driver, and they may speak the language a little bit and be able to help you out with, you know, because we struggle. We don't have interpreters in the free clinic necessarily. Most healthcare providers, and particularly doctors, are pretty good with Spanish, but the other languages, we have to kind of work around it, and sometimes it makes it really challenging to figure out how to interview people and to treat them. And sometimes I'll tell you, it's a complete failure because I can get no information out of them. There's no one there to interpret. All I can get is that they're there to have their meds refilled. They hand me a bag of meds You know, or I don't know if I told you this before, but I had one person hand me a cardiac cath report from China in Chinese. You know, at least they tried, but I have no way to interpret that, you know, and I can't base my treatment on that because I have no way. So it's really tough sometimes. So judge the reliability of the informant and how willing they are to communicate to you. Reliability leads to consistency of information. And note any special circumstances. Do they have an interpreter, or do they have someone that's an assistant to them? One of our Olympians didn't go to the Olympics in Japan this year. Because of COVID, they scaled back who could go with the athletes, and this person had an interpreter assistant that helped them. And she was one of the track and field people, and she couldn't go because they wouldn't allow that person. It was really sad. And I don't see why they couldn't have made, you know, an exception because that person really needed the person, but they wouldn't do it. So the reason for seeking care, it can be a spontaneous statement. Usually it's in the person's own words. So you put it in quotation marks. Very brief in the own words. So if we're looking at this, and I'm going to switch over to this now. Okay. So the chief complaint, and that's what CC stands for. This is their data up here, their initials, their age, female gender, and Caucasian, okay? And again, it is important to know race and ethnicities in your documentation because certain meds work better in certain populations than other populations. It just has to do with somehow how the body functions and certain systems in the body. And also, certain diseases run in certain populations. For instance, my granddaughter just had some abnormal lab results that were just done, and it showed that she was anemic. And my daughter, because she's not medical, didn't know to ask questions, but my granddaughter's, her dad's Black African American, and her grandfather on my daughter's dad's side and stuff came from Italy. Well, in the med, there's a type of anemia, which is not iron deficient anemia, it's a different type of anemia, it's called thalassemia. And if you have that, and if I gave you iron to supplement for your anemia, I could kill you because it's the way the iron's processed, not the fact that you don't have enough iron in your body. So we're gonna have to follow up on that with the doctor. And once again, you know, some people are good with follow-up and some people aren't. So anyway, this person comes in and their chief complaint that brought them in is pain in my chest. It's in their own words, I put it in quotation marks, okay? If the person can't narrow it down to the most important or most urgent, or if they can't communicate to you what really is the problem, you can fill this in your own words, just don't put it in quotation marks. And keep it as brief as possible. Because the next section is history of present illness, or HPI, okay? And this is the part where we really talk about those 7 questions that we ask, okay? And those 7 questions is, what's the problem, which we've already established, pain in the chest. But the first question is, what's the location? So I ask the person, where's the location of your pain? And we want to narrow it down because the chest is a fairly large area, the belly is a fairly large area, okay? So ask them to take a finger and point to where it hurts the most. So if they're here mid-sternal and this is where it's hurting, I have 3 choices now. This could be heart, this could be lungs, or it could be musculoskeletal. I've got to figure out what it is, all right? We always assume when they say chest pain that it's the absolute worst and it's the heart, okay? And that we're dealing with a heart attack until we can prove otherwise. And that's why when you come in the ER for chest pain and you say you're short of breath, that could be lung, okay? But it could also be heart. We do a chest x-ray, we do an EKG within 10 minutes of you getting into the ER, unless you're having that STEMI, boy, we got you on the monitor and we're already doing it, okay? But if it's just chest pain, but not the STEMI, we do the EKG and we do lab work and we look for troponin levels, which is an indicator of whether someone's having a heart attack or not, okay? And so we look for those things. And, you know, a heart attack can progress over periods of hours. Stroke can progress over periods of days. So we have to keep that in mind, okay? So with this person, the onset was 30 minutes ago. Now, chest pain usually radiates, especially if it's heart related. So they may come in and it's in the center of their chest, or it may originally started in the center of their chest. We call this mid-sternal right here, because that's where our heart is. Most people's heart is right center here. Some, if you have a big enlarged heart, maybe more over to the right, but right here. And so we say, does it radiate? And chest pain related to heart, or angina, which is chest pain, also will either go up into the neck and the jaw on the left side, and or it will go down the left arm. Okay, that's what we think of as traditionally cardiac pain. However, women can have lower back pain, abdominal pain, and have overall weakness. I remember reading the interview that Rosie O'Donnell, the actress, gave, and she had almost a widowmaker heart attack. So it was in a really bad place in her heart, and she's lucky she was in the parking lot of a health facility, because otherwise she probably would have died. So she said she went out to her car from an appointment. She went to get into the car, and all of a sudden this overwhelming sense of fatigue hit her, where she could barely move. And she was gonna help this lady get in her car that was having trouble, and she couldn't even do it. And she realized that she was in trouble. So women tend to have different kinds of chest pain. It's not traditional. And unfortunately, women get brushed off in the ER and by medical providers because their pain isn't the traditional that we think about. And so women have a higher chance of dying from a heart attack because they're brushed aside or poo-pooed that this isn't really chest pain or heart related because it's not in your jaw or going down your arm. And that's not true, okay? So getting back to this person, they say it's non-radiating and it's mid-sternal. So next thing I do is I want to quantify their pain. And the way I quantify it is I ask them on a scale of 0 to 10, which is called the Likert scale, L-I-K-E-R-T. Tell me how, with 0 being no pain and 10 being the worst pain you've ever felt, tell me what your pain level is. Well, my heart pain came in and she said it's a 9 out of a 10, okay? You will have people that will tell you it's a 25. I hate them, okay? I gave you a scale of 0 to 10, just say 10. I didn't give you 25, all right? But they did. They think it's funny, all right? No, I've heard the joke like 25,000 times. It's not funny anymore, right? So anyway, this lady's a 9 out of 10. So I've quantified the pain. And then the next thing I want to do is I want to ask her what it feels like. So I'm qualifying the pain, okay? So I give her some choices. Is it stabbing, aching, burning, throbbing? Does it feel like pressure? And when I do this, this lady says the pain feels like an elephant on my chest, which a lot of heart attack patients will tell you. They feel really severe chest pressure, they can't breathe, and they feel like an elephant is sitting on their chest. Don't know if you saw it in the news yesterday, but scientists at Harvard think it's a great idea to take DNA strands of the woolly mammoth that is now deceased and interact with an African elephant and have a new type of elephant that will roam the Arctic and free us from climate change. What could go wrong? Jurassic Park 1, 2, and 3, okay? So anyway, so the elephant on the chest. Constant in nature. So another thing is, if they say they're in pain, is it constant or does it wax and wane? Does it come and go? You know, and this patient maybe could say, it was worse 20 minutes ago, but it's a little bit better now, you know, or all night long I felt it and it was coming and going, you know, so you got to ask, is it constant or is it waxing and waning, okay? And this person tells you, like, to give you an idea of when it started, she says she was watching TV when it started. So she was very sedate. She wasn't out there shoveling snow or raking leaves in the yard. Shoveling snow does cardiac patients in, or people that don't even know they have a heart problem. They crumple and die in their driveways. Extreme cold shrinks the aortic artery of the heart, and as a result, people don't get the blood supply that they need to the heart muscle. They end up having chest pain, and they die before they even get inside. People with angina don't do well with extreme cold. So if you know someone that has had a heart attack or has angina, or someone that, you know, maybe has a history of chest pains in any way, shape, or form, you don't want them out in your driveway shoveling snow, all right? So, and any kind of pain is really bad when you're just sitting around doing nothing, that's really ominous, particularly for cardiac pain, because that means like this is really probably a big problem that's going on. Versus if you're out there, you know, and you just walked a mile or you were lifting weights or something like that, okay? She is positive for associated shortness of breath. So the things that happen with a heart attack is shortness of breath. They will sweat like a pig, diaphoresis, that's the word, diaphoris, diaphoresis, diaphoris. They will have numbness or tingling in their left extremity and maybe up into their jaw because there's a change in blood flow, so their extremities start to tingle. They may feel dizzy because they're not getting as much blood up into the brain. They may have a syncopal episode. This lady says she didn't, and I will tell you what a syncopal episode is. If you've never had this because you have sinus or middle ear problems, syncope is when the whole room just turns and spins, and literally you have to hold on to something to even walk to like the bed or the bathroom, because the whole world, you can barely stand on your feet because your head is just like spinning, okay? Worse than the worst hangover you've ever had, okay? So that is a syncopal episode. They may lose consciousness for a few minutes with a syncopal episode, and it's because there's been a blood flow change, all right? Ex-husband was in the ER 3-4 weeks ago and had a stroke, and he was out for a while. He doesn't know how long he was laying in the ER. And then the idiot, he was an idiot when I knew him, and he's an idiot now still, basically went inside the house and didn't tell anybody. He was home alone. His wife was away for the night, and so he didn't go to the ER. And so she gets home the next day, and it's now over 24 hours, and he's like, oh yeah, I all this happened to me. I passed out and everything, and like, we're going to the ER, and it ended up being a stroke. But that said, he's extremely lucky. It was a good warning shot over the bow, a little bit of speech impediment, a little bit of swallowing issue, but not like total paralysis on one side and whatever. Lucky man, okay? And for my kids, I'm glad that he was lucky. So anyway, syncopal episode, no syncopal episode. And then we go into what causating or alleviating factors. So what makes it better? What makes it worse? So they may say, I changed positions and the pain got a little bit better, you know, if it's an orthopedic injury, or I, you know, had this splitting migraine and I went and I laid down in a dark room and that made it better, or I took my medicine and it made it better, or I took an aspirin and I made it better. Cardiac pain, you want to get a baby aspirin in them. If you don't have a baby aspirin, cut an adult one in half. Give it to them before the EMS even arrives. Don't give it if there's a stroke, because you don't know if it's a clot stroke or a bleeding stroke. You don't want someone bleeding more. But if they're having chest pain and you think that it's a heart attack and they look pale, they may be cool, clammy, or they may be sweating profusely, diaphoretic, or have shortness of breath, or maybe have cyanosis around the lips and the mouth and the nail beds, get the aspirin in them. EMS is going to give them another aspirin in the ambulance on the way to the ER, and when they get to the ER, we're probably going to give them at least 1 or 2 more baby aspirin, because it has anti-clotting factors, and it does help preserve cardiac function, you know, in the event of a cardiac problem like a heart attack, okay? So for this woman, she says that she had the sweating. The other thing that they can do is they have nausea and vomiting, all right? They may be just nauseous, or they may go ahead and vomit. Very common. Remember from anatomy and physiology, that vagal nerve that runs from basically your head all the way down to your butt, to your rectum? It runs through the GI system. So, and it also has to do with the heart. So it's all aggravated, so they may vomit. And if you have a patient like that, have the emesis basin, that little kidney-shaped plastic thing that they puke in, or a big basin ready for them, because they're probably going to vomit. Have it at the bedside, okay? Because they're going to go, all of a sudden, they're going to go, oh my God, ugh. All right, so have it prepared. In the ER, we do have vomiting like bags, like the airplanes do. And so this lady was also, I think I missed it, but shortness of breath, positive for nausea and no vomiting, but she was positive for the sweating, some dizziness reported, no syncopal episode. And so nothing that she did helped with what was going on. Nothing made it better. No alleviating factors identified. What makes it, she did take a baby aspirin about 20 minutes ago before she called 911. And it's now like 30 minutes ago. She may have taken, like, maybe she has nitroglycerin because she has a history of heart problems. So, maybe she took some nitroglycerin, which we're going to give her anyway in the ambulance, and we're also going to give it in the ER when she gets there, okay? So nothing makes it better or nothing makes it worse. The very last question we ask is patient's perception of the problem. What do you think it is? I didn't put that in here, but give you an example. In clinic, I had a guy come in with chest pain. Well, I went through all the things and I pretty much figured out it was musculoskeletal because it was way over here by the ribs. And when I pressed on it, it made it worse. When I let go, it was better. We went through the whole visit and I'm like, do you have any idea at all? Nothing. You couldn't think of anything. And just before he left, he goes, you know what? I was lifting a refrigerator with my buddy up the stairs this weekend into his apartment. I'm like, okay. So he had his V8 moment and he remembered that he was lifting the refrigerator. I've had another person that tell me they were moving a bicycle up into their apartment and hurt themselves too. So sometimes the patient is right spot on. They know what's going on, and that information is really important. Sometimes they have no idea. Sometimes they will tell you something that you know in your head has nothing to do with whatever's going on with them. There's no connection at all, not even a remote connection, all right? But document what they think, okay? So then we move into PMH, which stands for past medical history. And this person has CAD, which is coronary artery disease, HTN, which is hypertension, CHF, which is congestive heart failure. They have a history of hyperkalemia. When it's spelled with a K, it means their potassium level is elevated. If it's spelled with a C, it means their calcium level is elevated. Hyperlipidemia means that their lipid levels are elevated. It's related to cholesterol, or they may say hypercholesterolemia. COPD is chronic obstructive pulmonary disease, so she's got respiratory issues to start with. I duplicated hypertension by accident in this. Alzheimer's, dementia, and hypothyroidism. Thyroid is really connected very strongly with heart. It has to do with the heart beating and such. So people that have thyroid problems, whether it's hyper or hypothyroid, they can have a change in heart rhythm and the way the heart's beating. So now that we've got the past medical history, we move to past surgical history. So this lady had a hysterectomy in 1975. She had a left hip replacement surgery in 2009 and a cabbage ×3. So there's two things that they can do when someone has a blockage in the heart. Like my brother, he got a stent put in a couple of years ago. You all know the ballpoint pens, if you unscrew them, that little corkscrew spring that's in it, that's what a stent looks like. Some stents down in the kidneys and stuff may be bigger, but for cardiac, they're very tiny. And what they do is they're not sprung out, they're like collapsed, and they go up through the groin and up into the heart itself and then into the vessel that's involved. And then they open it up and that spring pops open, and where they had plaques, here's the vessel, they had plaque that almost occluded their vessel, so they're only getting blood through here. That spring opens it back up so that they have normal blood flow, okay? And if they change their diet, their lifestyle, stop smoking, manage their diabetes, they may live very well with, one stent, 2 stents, and they're good. But a lot of people have trouble changing their lifestyle, so as a result, they end up clotting off their stent again. And it may be that they have to take it out and put a new stent in, or more than likely, like my brother last month, started having chest pain again after about 8 years. And sure enough, he was like 98% occluded in a couple of his arteries. So he had coronary artery bypass graft, which is what CABG stands for. I don't know how many vessels. I'm going to see him when I go down to see my dad, so I'll get the chance to talk to him. So, but he did well. So open heart surgery is they crack the chest open, retract it open, and they actually tackle the heart itself. They go into the legs and they glean the saphenous veins in the legs, one or more. They cut strips of it, the vein, and then they tack it onto the heart. And if this is the heart muscle here, not a very good heart, but if this is the problem here, your 4 chambers here, if this is the problem, the artery that's involved in the heart, what they'll do is they'll take that vein graft and they'll go around that blockage with whatever grafting they're going to do. And they bypass it by putting a piece of your leg vein in there, okay? So that's what they do. Some people, if they're too old or poor surgical candidates, they may choose to medically manage them for the heart blocks or whatever. There's a lot of data that suggests that older people in particular do just as well with medical management, with medicines versus the surgery. I'll tell you right now, nothing against older people. You know, obviously I've got a dad that's real up there and stuff, but I really believe in this whole circle of life thing, and I believe that, you know, we were born, we age, our body ages, and at some point we're all going to be leaving. And, you know, I believe in technology and science, and I believe in using technology and science, but do I think that we want to use like the utmost technology and science on our older population? It depends on the person. I know 85-year-olds that are more active and doing more than I am. God bless them, okay? And they're with the program and they have quality of life. But I know that a lot of families often hold out hope, you know, and they want every single thing done, you know, whether or not that it's the best thing for them or not. And I just don't believe that, you know, once you hit a certain point, you know, like putting a feeding tube down, you know, a 92-year-old, like that makes no sense at all, because they could aspirate that feeding tube content, like it's baby formula, they can aspirate that into their lungs and die of pneumonia. Like, why would you put them all through that? You know, like there's no reason for that. So I think that people have to think real strongly, and I know you love loved ones, and I love my loved ones, but what is best for them, you know? And at some point you gotta like let go. You're not gonna keep someone around forever. And it's just like Dad. He's had 96 really fantastic years. He's traveled, he's been in the military, he's had a great job, he's had great retirement, you know, he had, you know, 2 wives, did a lot of love in his life and stuff. And so the long and the short of the story, it's time, you know, and if it happens, yeah, I'll probably be sad initially when it cries, but it's for the best. It's part of the whole gambit of things. So, all right, medications. So you have to document the medications that they're on. By law, the Joint Commission of Hospitals requires nurses to do a medication reconciliation when the patient comes to the hospital and when they leave the hospital. So the doctor's going to have maybe some of this information, or the old medical records, some of the information there. But like I just went into Beaumont for my neck surgery in April, and I had fusion of one of my upper discs in my neck, and I had 3 previous ones done in 2010, and their records were old. They had me on a different blood pressure medicine, so we went through the whole list. Are you taking this? Are you still taking that? Are you taking this? Nope, that changed it, put the new medication in, and you know, it was all good to go. And then when someone gets ready to leave, we go over it again. Lucky for you guys, you are not gonna have to, or you should not have to learn generic and brand name drugs. The nursing NCLEX and stuff is now moving to just generic drugs, so you will know them by one name. Polypharmacy is a big problem with our elderly people, meaning too many drugs, and they interact with each other, or they get put on another drug and it's the generic and they're taking double what they should. My cousin's father, he was on a psychotropic drug, and one was a generic and one was the name brand, and he didn't realize it, and he was double dosing himself and he almost died. Like, he was so out of it, and they took him to the neurologist because they thought he'd had a stroke, or maybe he was having early onset dementia. And so then the neurologist went and did the medication thing and like, no, this is the problem here. And he was very embarrassed. He's a very smart man, but he got confused. It's so easy to get confused. I walk into my dad's house in June, and literally the whole peninsula that sticks out the counter in the kitchen is cluttered with medication bottles. They're not taking all that crap. But elderly people are very frugal, particularly people that have lived through the Depression. And medications cost money, so they don't want to throw it out in case their doctor changes their mind and puts them back on what they stopped. So they save it, and they leave it on the counter. And this is why my father bled out too, because he was taking 2 different types of ibuprofen 3 years ago. And he didn't realize it because, one maybe had the Advil name to it and the other had ibuprofen. And he didn't know they were like essentially the same blood and, interfering with his clotting and irritated the stomach, and that's why he bled out. So they get really confused. So we need to make sure that they know what they're supposed to be taking when they go home, and we reconcile again, okay? So you want to list the name of the medication. You want to list the dose. If it's 2 tablets, 2 tablets. If it's 1 tablet, 1 tablet. If it's just 50 milligrams and the supply, the pharmacies dispense 50 milligrams, and that's 1 tablet, okay? Now you're gonna have to learn some Latin. PO is by mouth. I is OS is left eye, OU is right eye. You're gonna learn these abbreviations, okay? And because OS and OU can be confusing, a lot of people are forgoing the Latin on that and saying right eye or left eye because people get it screwed up, all right? And BID is twice a day. So QD is once a day, BID twice a day, TID 3 times a day, QID 4 times a day. If it's 5, 6, 7 or whatever, then we go to numbers, times with a X a day, okay? And we always put the route the medication is. Is it by mouth? Is it a cream? So it's topical. Is it sublingual? It goes under our tongue. Is it buccal? Goes between the tongue and the jaw. Is it intranasal? Is it into the eye? Is it into the ear? Or is it per rectum? PR, per rectum. How do we give that medication? It matters. When I was a brand new nurse, I worked at Albany Medical Center up in upstate New York, and there was a resident who was a really nice guy, and he had a team of interns working under him. Interns are your first year med students, okay? Residents are 2 or 3 years, and they have more responsibilities. So him and his team were rounding, and they were working up on the chemo floor. And at that point, you didn't have to be certified in chemo to administer chemo. Now you do. All nurses that work with chemo are certified because you can give somebody a lethal cocktail of chemo. So one of his students gave a drug that should have been given intrathecally in the spine, IV, and sent a young woman who was pregnant into a coma, which lasted like 9 months. News picked on it. It was all over upstate New York and national news. And then Bob Easton, a photographer down in Miami, within 2 weeks was overdosed on something as well. So that was in the news. So make sure you are fully clear on how you want to give a drug. Nitroglycerin, cardiac emergency med. We can do long-term nitroglycerin, which is a patch, a flesh-colored patch that sticks on their chest wall someplace. We can give nitroglycerin sublingually in the event of an emergency under the tongue, and it's rapid absorption. We can give it buccally, rapid absorption. They can do it nasal spray, rapid absorption. Or they can do IV, which is real rapid because you're putting it right in the bloodstream. It doesn't have to go through the tissues or the vessels, like it's right there in the blood already. Or we can do an IV drip with nitroglycerin. So there's many, many ways with that particular drug in which we can give it, okay? And let me just put 2 cents in here while we're talking about medication patches. We can also do cream on the chest with nitroglycerin, and that's what we used in the ER down south. But up here, when I got to Detroit receiving, we were doing it IV. So medicine can be regional, where one region does things one way, another region does it another way. But let me be clear, if you have a patient and you're gonna administer a medication patch to that patient, make sure you locate the previous patch, and if you think it fell off, make darn sure that it fell off. Because a lot of the times they can not only be cardiac meds, but they can be narcotics, and they have sedative properties. Once I had a patient come in that had 5 pain patches on, and she was barely breathing. So, you know, we figured out we're taking all these pain patches off and wiping the medication off her skin so she wouldn't absorb anymore, okay? And then there's a story about the little elderly guy that kept coming into the ER. He came in like 5 times over the course of like 5 or 6 hours with his wife. And, you know, they were sending him back home, and he was coming in because he was basically going unconscious, and then he was alive, you know, brought back again. And what it turned out was he had 2 creams. He had nitroglycerin cream at home, and he had a lotion he was supposed to be putting on his skin. Well, he got the 2 confused because he's older, and he was rubbing his skin, a large portion of his skin, with the nitroglycerin cream, which was being absorbed into the body and would bottom out his blood pressure, and then ended up in the ambulance and back to the ER again. So we need to be real clear in the education that we give to people. We need to read labels as well. So anyway, you go through the rest of the drugs. Lasix is a water pill. That's once a day. Synthroid is for the thyroid. That's always dosed in micrograms, and that's usually a once daily medication. Atorvastatin is a statin drug, which is for cholesterol. That's once a day. Aldactone is to help with fluid, and it works on the kidneys. That's once a day. Aspirin is an anticoagulant, and it's also for people that are diabetic. All diabetics should be taking a baby aspirin a day because it increases your lifespan, studies show. And also cardiac patients, if their doctor recommends they go on an aspirin, they should be taking a baby aspirin. Baby aspirin is 81 milligrams, and adult aspirin is double the amount. Advair discus is an inhaler. It's a round discus that they breathe in and inhale the powder into their lungs. So that's for her COPD. And then an Exelon patch is another topical patch that goes on the skin. Now, allergies. When we talk about allergies with our patients, we want to make sure that we document all allergies. Start with the medications, okay? And a lot of people know that they're allergic, but they were real little when they were told that they were allergic. Like if you talk to my youngest daughter, she has a buku array of antibiotics that she's allergic to. She doesn't remember, but when she was 2 and the first antibiotic for an ear infection, she had huge flat patches of hives all up and down her arms, her trunk, or whatever. The worst allergic reaction, not that that's not worse, because every time you're exposed to what you're allergic to, the reaction gets worse and worse and worse. So it may start out with just hives and itching, which you can manage, but if you've been exposed multiple times, your body jumps to a more severe reaction, and it could be your lips, mouth, or throat that start to swell off. And if it's your throat, you're in trouble because you won't be able to breathe. And that's called an anaphylactic shock. All right? I had worked for a guy in a nursing home. He was my boss. He was the director for the nursing home. And it was Christmas time. People brought in a lot of foods and stuff. And he knew that he was allergic to some peanuts, but he didn't realize it had peanuts on it. And he thought he would be okay because he just got a little itching the last time. He had to walk to the ER, which was across the street. He barely made it across the street to the ER. All right? Don't ever just think, you know, you'll be okay because the first time it wasn't a big thing. The other thing is that if it's a severe reaction, people should be wearing bracelets, an allergy bracelet, to warn people. We had a nursing student a couple years ago where a student dropped down in class and had a reaction. And another student was right on the ball, went through her purse, found her medication, was able to like take the health history and stuff, and we got her help, and it was okay. And it was allergic reaction to something that she had taken, okay? So then I worked with a guy who was a nurse who, for some reason, had an allergic reaction. I think it was a bee sting, was out in the yard. And so he had Benadryl at home. If you're at home and you have Benadryl, take if it's 25 tabs, take 3 of them or 4 of them. If you're a healthy adult, that should be fine. Don't give 4 of them to an 80-year-old woman that's only 80 pounds because she can't handle all that Benadryl. You'll wipe her out. But so he was at home, he had Benadryl, so he went ahead and he only had 50 milligram tabs, so he took 2. And then he decided to drive himself to the ER because he wasn't feeling better. He almost fell asleep like in the parking lot, which he would have probably died. So make sure that you're not like, or nobody's driving themselves if they're going to take a large amount of Benadryl and stuff, because it's very sedative, okay? So you want to put what the allergen is. So PCN is an abbreviation for penicillin, and this person gets hives with that. Now, do they have environmental allergies like cleaning supplies, dust, mold, things like that? Seasonal allergies, pollens in the air, worse in the spring or the fall. Some people, they know every month, the year that's real bad, they get hacking cough, their nose gets all stuffed up, their eyes water, they know that they have a seasonal allergy. And then lastly, food allergies are really important, particularly people that are allergic to peanuts and such. We need to know, we make sure that their food's not prepared in the kitchen near where maybe peanut and other nuts are stored and such. And believe it or not, if you're allergic to macadamia nuts, one of the inhalers, and I can't remember which one now, I'll look it up, but one of the inhalers can cause you to have an allergic reaction because it has some kind of nut derivative in it. And so macadamia nuts. So the next is immunization. So I usually ask, are they up to date? With an adult, that's usually suffice. If they're coming in my ER and they've had any kind of a trauma or injury or cut, abrasion, wound or anything, guess what? You're probably getting a tetanus shot. We say 10 years for tetanus shots, but if you come in the ER at 5 years, they're going to give you another one. With your permission, but they're going to give you another one. And it won't hurt you to get another one because they want to make sure that that's fresh so that you don't end up with tetanus. I think we all learned in history about the guy that built the Brooklyn Bridge, and his leg got caught between the barge and the dock, and he ended up dying of tetanus because he contracted tetanus. That's how I always remember tetanus. But influenza vaccine, make sure we ask, have they gotten it this year? Now's the time. They're starting to get influenza vaccines. The herpes zoster vaccine, you can get it like from 55 years on. That's a fairly new one out on the market, but that's another good one to get, and tetanus. And of course, now we're going to be asking about COVID vaccines. Did you get Pfizer, Moderna, or did you get Johnson & Johnson where you only got one dose? Did you get a booster? Yeah, because maybe they're an older person. They're going to start boosters probably next week. So, we'll be asking about booster COVID vaccinations too. And I haven't heard yet, hopefully they'll come out with this, but I got Moderna, so I don't know. Pfizer's the only one with the booster approved yet, so I don't know if I have to wait for a Moderna booster or if I could take the Pfizer booster. It's still the RNA kind of stuff that's floating in the blood. I don't know, so we'll see what happens. A lot of healthcare workers that got them last December and January are going to be coming due, so they're going to need boosters because they're almost to a year. And such, and so their whatever immunity it provided is probably very waning at this point. I just read an article yesterday about some woman, she was 63, that died because she traveled to Mississippi. She was vaccinated, 2 vaccines, but Mississippi is like the hotbed of COVID, one of the hotbeds in the country right now, although Michigan had 66,004 cases yesterday. And of course the GOP legislature has taken all Whitmer's emergency powers away from her, so she can't do anything to protect us right now. So just beware, we are in a hotbed of COVID here in Michigan, and it's the Delta. So family medical history. So the book talks about a genogram, which is a diaphragm with lines and such, like a family tree, and you use squares, circles, and triangles to indicate diseases that run down through the family and stuff. My way, the way you do it in a note is much simpler. We really don't have time to draw out a full phenogram. We took my granddaughter to a geneticist because there were some problems in February, so we wondered if it was genetic or not. And the lady did an interview, but she didn't do a genogram. But I'm sure there's some geneticists that still do that. Some instructors prefer to give you an assignment to do your own family history genogram. I chose not to because I think it's more functional to learn just to do the list. So start with either your father or your mother's mother and father, the grandparents. If they're adopted or they don't know, that's fine. Just put adopted, unknown. If they do know, put the age that they died at, or if they're still alive, you can say still alive. If they're deceased, put that they're deceased and put why they died. Was it MI? Was it COVID? Was it, diabetes related? whatever you know to be true, and then anything else that you know that they had. For instance, I know that my grandmother died at 99, my dad's mom, from a stroke, but I know that she had high blood pressure, she had cholesterol issues, she had congestive heart failure. I know all these things because I've really researched my family with genealogy, and I know, okay? But a lot of people don't know. And then my grandfather, the paternal grandfather, and this person is deceased at 75, but unknown cause. Now, I know that my grandfather actually died of a heart attack. He had retired like 6 months earlier from the post office and had a major heart attack in the middle of the woods in the Adirondack Mountains, and no hospital, no doctor available, and died, and I know that. But good news is he died with 7 trout in his basket, so he had a good death. So anyway, and I know his parents. I know his father died of a massive heart attack at 75 because of the genealogy research I did, and I know that his mother died in 1918 from the Spanish flu. So I have their birth certificates, and I know that. I know that aunts in that side of the family, there was one aunt with breast cancer, but breast cancer is usually more concerning in your mother's side and her sisters and her mother and grandmother versus your father's side. So anyway, you go down through, then you do the maternal grandmother and grandfather, and then you do your mom and your dad. If your mom and dad, again, are still alive, you say still alive. They may be healthy, you say healthy. If you don't know where your dad is or whatever, unknown, and again, adopted, and just what you know to be true as to the things they had medically going on with them and what was the cause of their demise. And there's, at least 5 or 6 things genetically that could cause problems. I need to know if there's any early cardiac death in your family, because age 50 or younger is considered early cardiac death. So it's good if you know about your mom, dad, grandparents, and great-grandparents' cardiac death. Now, I have cardiac death in my family with my grandfather and my great-grandfather, but I know it's not early cardiac death, okay? Because they were all older than 50. But there's other diseases too that can run through the family. So the very last category is social history that we're getting. And so with smoking, there's 2 ways to document smoking. I don't like the one way because honestly, usually people start smoking about age 12 or 13. And so by the time we see them in adulthood, they're smoking now 2 to 3 packs a day, but they didn't start out with 2 to 3 packs a day. So it's hard to estimate their pack years and stuff. So you can either do it packs per day and then say times how many years, or you can do it pack per day. The way you do it packs per day is if you have a 2 pack per day smoker, and they've smoked times 20 years, 2 times 20 is 40. So they have a 40 pack year history. Either one is okay. There's no one versus other that's better than the other. I just use pack per day myself, but that, that's just a choice. Drugs, you can keep in mind that marijuana is now legal in a lot of states, so people are either using pot, and so the stigma should be going away from that. But the other thing is, and then people won't be as careful about disclosing that to you, because if you see them in an emergent situation, they're worried that you're going to report them to the police. And you always have to assure people that no matter what they tell you about their drug or alcohol use or whatever, you're not a reporter of that. You're there to help take care of them, and you need that information to take care of them, okay? So anyway, and also, my brother's 75, and so he was the hippie age of the 60s. So, they're up there now. So it's not necessarily the 20-year-old that's smoking, in their car anymore. No, it's older people that are smoking in their homes and stuff. So we need to know. Some of the CBD oils do come from hemp that will make them test positive for cannabinoids. So you have to kind of ask them about over-the-counter drugs that they may be taking. Are they eating edibles? Things like that. We need to know that information. Some of the 60 people did drop acid. I dated a guy in high school, not high school, but college one time that did acid one night, and So it's not uncommon to find people that have done it maybe once or twice or something. Hopefully they're not still doing psychedelics or things like that. But I will tell you, psychedelic mushrooms are in. And some people are using it for trauma and stuff. And there is a drug that they use in Appalachia that is gleaned from some root down in South America. And I can't remember what it is, but there's a show where these people meet and then they do trauma therapy with this guy that leads them through with this plant-based psychedelic and stuff. And it makes them have diarrhea and puke. And to me, that would be two off-putting things. I don't think I would want to do therapy where that was going to be part of it. But anyway, the long and the short of the story is that, you know, people, some people are doing, you know, mushrooms and stuff, so you have to ask. Then we move to alcohol. You need to estimate how much and how frequent. Yeah.
Do you collect information about using vapes, like vape pens? Is that included in the smoking history, or?
If it's a marijuana one. But
not
yeah,
vaping?
if smoking, yeah, you can put that under the tobacco. That was a good one. Okay, so alcohol. So are they drinking 3 beers, or are they having a couple glasses of whiskey? What kind of alcohol are they using, and how many ounces, and how many times weekly? If they quit, that they quit 3 weeks ago. You might, under psychosocial history, want to note, did they go through a program or did they just quit, right? People come in, and some people are used to, you know, having 1 or 2 every afternoon when they get home from work. And so they are now admitted to your hospital floor. Took care of this guy one time. He had respiratory issues, and he was a pleasant, nice man on the first night I took care of him. Very obese. And the next night, he was awful, pulling IV lines out, trying to jump over the bed rails in the bed. I mean, confused, disoriented. He was going through DTs, and I came from a non-drinking family, so I had no idea. This was when I was in my early 20s. So I had no idea. So by day 2 or 3, the alcohol is now like moved out of their body unless they brought something with them. And so you're going to see people going through delirium tremors, which is DTs. And it can get really freaking scary. And then I took care of this other guy one time. He was had an alcohol drip, which is an old-fashioned treatment. Now we use Librium and some of the anti-anxiety type of things to help them, Valium and such. But this guy was given an alcohol drip, so it was an IV going into his arm, and he was going down the hall with the IV pole going like this at people and everything, trying to leave the hospital. It was really scary. So, you know, if you ever get someone where their behavior is just like not connecting the dots, like, what is going on with this person? They were real pleasant yesterday and they're not today. What has happened in the interim? You know, think about the alcohol thing, okay? Exercise, this 82-year-old, she walks daily 3 to 4 blocks, God bless her. Tai Chi classes weekly, which is good for balance and, you know, movement with our elderly people. Nutrition and diet. So, balanced fruits. People will say, well, I eat a balanced diet. Well, what exactly does that mean? I know that I'm really bad with vegetables and fruits. Like, I'm lucky if I get 1 canned vegetable at dinner, because they're just not my favorite thing. So I don't necessarily have a real good diet, but I'm very low on fast foods. So, you know, I hardly ever grab McDonald's or anything like that. It has to be like really off the wall for me to grab fast food. So go through and talk with them. See if they're diabetic. Are they on an ADA, which is American Dietetic Association diet? And they're set by calories. You can have 1,000, 1,200, you can have 1,400, 1,500, 1,800 ADA diet. For people that are bigger size, they may be on a 2,000 or 2,200 calorie diet. If we get above that, then it's just plain obesity, you know, and stuff. Interesting fact, I never knew this, but insulin actually makes diabetics hungry. So, you know, it's not always their fault when they're craving foods. My dad's brother was a type 2 diabetic, and he ate everything in sight. I would watch him. We'd have a family gathering, and Uncle Dick, who could barely move any other time, would haul himself up to the buffet several times and go down through and pick and eat and pick and eat. And he'd watch you make everything from in the kitchen and everything. And I always felt really bad afterwards because I didn't know that insulin actually makes you hungry. And so probably a lot of his behavior was from the insulin that he was taking. So, sex, get used to talking to people about sex life. Like, are you sexually active? If you're still sexually active, are there any problems? If there are no problems, if they're in childbearing age, are you using birth control? A lot of women who are menopausal will stop taking precautions, stop using birth control. I had a lady one time, she was in her late 40s and came in and she's like, no, I'm still menstruating. And I'm like, well, what are you using for birth control? I'm not. I'm like, do you want another baby right now? Like, I don't think so. You know, she's like, no. And I said, well, you know, you can still get pregnant. They can get pregnant until the time that they've not had a period for a full year. Once they go a full year, they are officially in menopause city. Hallelujah. And then pregnancy is not an option anymore. So make sure you find out, you know, are they still menstruating, when their last menstrual period was, because you want to document that, so that when we're ordering meds for them, we make sure that they're not pregnant when we're giving them meds right now, okay? Occupation, this lady was a retired beautician. Support system, her daughter and best friend. Safety, she doesn't drive, she wears a seatbelt 100% when she's a passenger. Other things that fall into safety that you can ask and include here are guns in the house. Are there guns in the house and are they locked up in a gun safe? Do you use bicycle helmets when you're out or on your motorcycle? Do you, let's see, what else? Smoke detector. Are there smoke detectors in the home? That's another safety, okay? So those are really important. If there's small kids, are all the chemicals locked up in the cupboard where they can't reach? If they have teenagers, is all the alcohol locked up where the teenagers can't get to it? All right. And as a mom of 5 daughters, you know, I had one stumble in the door, stone drunk one time. It happens. So anyway, I took her over to her dad's house. Wasn't having it. So anyway, long and the short of the story is, the last thing we have to ask about is their residence. Where do they live? Do they live in an apartment or do they live in a house? Are there steps up to the house or the apartment that they're going to have to navigate upon discharge? Do they live alone? Who do they live with? Should be included here, because we don't want to send an older person home by themselves. If they go home and they return to the hospital in 24 to 72 hours, it's reported nationally. It's a bing on the hospital. If they die, it's even a bigger bing within 72 hours. So we want to make sure that we're sending somebody into a safe environment. There is a law called EMTALA for emergency room procedures, AMTALA, which says that we cannot just dump a patient back out on the sidewalk. And that's because there were hospitals in California that were taking indigent people out of their ERs, driving them across town and dumping them in some of the worst areas of the city just to get rid of them, okay? You cannot do that. We have to know that everybody has a safe place to go. And down at Detroit Receiving, when I worked there, we gave bus tickets, occasionally taxi vouchers, but we had people really abuse them. We had people that would call 911 so that they could get to downtown Detroit to our ER. They'd stay there an hour, they'd leave either AMA against medical advice, or they would just go through the system and get discharged, okay? Go to the casino, they were diabetic, they would be there all day long, barely eat because they're sitting at the slot tables or whatnot, and then come back and want a voucher to go home. Like, really? So it does happen. So, you know, we try real hard to make sure that they had a safe bus or taxi or whatever voucher to go home. Yeah, you see everything down in Detroit. You really do. Good, the bad, and the ugly. So anyway, the very last thing is the review of systems. Now, like it says in the name, we go system by system, and we include endocrine here, we include a general, but we go through all the systems. The difference between the review of systems is subjective, because we're going to ask the patient a lot of questions, and it's our last chance to get any information of something that's going on that might be related to the problem that they came to the ER for or came to the office for. The difference between review of systems and what we did last week, where we covered some body systems, but we also broke it down into like heart, lungs, abdomen. So we had some systems and then some organs, okay? Is that what we did last week was what we did, was it subjective or was it objective last week? Objective, because it was what we put our hands on the patient and we saw, we felt, we heard, okay? Good. So it's very confusing to students because they see this system here and they think that we're talking about like what we did last week, and we're not. And you can see as we go through it. So the general is fever, malaise, which is just not feeling well and kind of lingering around, chills, nausea, vomiting, unintentional weight gain or weight loss. So if someone loses 5 pounds in a month or 90 pounds in 3 months, more than that, that's a concern because that's an unintentional weight loss usually. If they say they're trying to lose weight, then you want more information like what did you change? Did you change your diet? Are you exercising more? How are you losing that weight? HEENT is for head, ears, eyes, nose, and throat. We asked, do you have any headaches, eye pain, change of vision, discharge, drainage from eyes, discharge, drainage from ears, ear pain, denies dizziness, denies tinnitus is a fancy word that you need to learn. It means ringing in the ear. People with middle ear and ear infection type of problems will have ringing in the ear. There's a syndrome called Meniere's syndrome, MENIERES, which is ringing in the ears, the syncope, the room swimming, or vertigo, okay, together, and ear pain. And so it's very annoying to people. Ringing in the ear is really annoying. I don't know if anybody's ever had it, but sometimes I occasionally get it and I'll be laying in bed, I'm like, oh my God. And it's just like, is it just me? Am I just thinking about it? And then it gets worse, and then it just goes away. Denies nasal or discharge or drainage, denies sinus pain or pressure, denies mouth pain or tooth pain, denies throat pain, denies difficulty swallowing or chewing, denies slurred speech. So that is all under HEENT. Then we go to the neck, denies pain or tenderness in their neck, denies trouble with range of motion of the neck, denies lymph node enlargement or tenderness, because in here we have lymph nodes. Some people call them glands, but they're actually lymph nodes, okay? Everything from your head drains through the lymphatic system down into your neck and is reabsorbed by your body. So if you have a cold or an upper respiratory infection, and everything is stuffy in the head or whatnot, it's gonna drain down through your neck, and these lymph nodes are gonna puff up, and you'll have them for a while. Some people with allergies have like chronic lymph node enlargement, and that's their norm, okay? Now, in December 2019, I swear I had COVID. It was before COVID went through the country. My husband and I were sicker than we've ever been in my entire life, and it started out as a sore throat for me. And this lymph node was the size of a golf ball. And one of the nurse practitioners upstairs, I took her hand, I said, Sherry, feel this? And she's like, oh my God. And I said, this has never happened. She goes, you need to go to the doctor right away. Of course, I was going to anyway, and I went, and they were worried about an abscess in my tonsil area. But I didn't have, abscess, and the doctor at the urgent care told me, she goes, if this doesn't go down in 24 hours, you need to go to like U of M, where they have a team of HENT doctors where they can work on this. She goes, because I think it's an abscess that's really starting to form. Luckily it didn't, but we were supposed to travel to Virginia that Christmas. We didn't go, neither one of us. I looked at him and he looked at me Christmas night, and we just said, I can't do it. And he's like, well, I'm worried about the hotel. And I said, let me call. And we only had to pay like $160 out of 400 and something. He goes, I can live with that. And I said, I can too. But I swear we had COVID. Like the drainage, it was this stringy phlegm going down the back of my throat. I felt like I was choking. I had to sit upright in bed to sleep. It was awful, absolutely awful. And then fever and chills and no appetite. It was awful. So I think COVID was in our society that fall. I've talked to other people that had people that they know that had similar symptoms and stuff. So respiratory, denies any cough, wheeze. Hemoptysis is a fancy word for blood in their sputum. They'll cough, they have sputum it's got either flecks of blood or streaks of blood or maybe even frank blood in it. And then anything respiratory, like she said she was short of breath back in the history of the present illness, don't repeat. Anything that's in that HPI section or medication section or vital sign, don't repeat it. Just say see HPI, see medication, see past medical history or whatever to get the reader to go back to reread that other area, okay? You need to be very precious with the time that you're given with the patient. Don't do things that are duplicate or a waste of time. Be very succinct in time and plan your time very well, okay? Cardiovascular, CHPI, denies palpitations or fast heart rate. So my eldest daughter, last month I went down and the one just had the baby. That night I get back to the hotel, I put my feet up, click on the TV, and my phone rings. And my oldest daughter, who's not always the most communicative person with me, says, "Hi, what are you doing?" I said, "I'm watching TV." She said, "Can you come and get me?" She lived about 40 minutes away. She goes and take me to the ER. I said, "What's wrong?" Well, since February, she's been having troubles where she's had extreme tiredness and lethargy. And she's having heart palpitations and she feels dizzy a little bit sometimes and stuff. And she can feel her heart, like the irregular rhythm in her heart. And they haven't been able to figure it out. Well, she was having an episode. So they did do an EKG, not at the ER that night, but during the early part of the summer. And she's actually having premature ventricular contractions, which makes it like her heart skipping. It's like the heart beats before it should be beating, so it's not regular. It's, instead of being ba-bum, 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 it's like ba-bum, 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 you know, something like that. And she's feeling that, and then it makes her more anxious. And apparently there's a small percentage of the population that can have these PVCs, and it doesn't really mean that there's something wrong with their heart per se, but it's not a big deal. You just learn to live with it. So they've got her on some anti-anxiety meds and stuff to try to calm the situation down. One of the antidepressants helps with the syndrome too and stuff, but we don't know if she was exposed to COVID at some part, because I had a student last fall that had COVID at Christmas that was having cardiac complications and stuff. And it could very well be that she didn't know it, but she was exposed to COVID someplace on her own. So the PVCs that are concerning is when they're all together and you have 3 or 4 in a row, because if you have 3 and 4 in a row, you could send your heart into a flat, non-rhythm heart rate, and you can, code and die. So PVCs on their own are not a concern, but if you're, when I was in cardiac floors as a nurse in the 80s and 90s, if somebody even had one every so often, like my daughter, we were medicating them. They don't do that anymore. So only if they have a whole bunch, they'll think about medicating them. All right, so the next is the gastrointestinal system. States appetite is adequate, denies dysphagia. So dysphagia is difficulty swallowing. DYSPHAGIA, dysphagia, swallowing difficulty. Dysphasic or aphasic is trouble speaking. So this patient denies difficulty swallowing. All right, she denies food intolerances and pain, and has one formed bowel movement every day. Neurological, we talked about diarrhea and stuff last week, didn't we? Yeah, okay. So, because people really think they are, but they're not having diarrhea. And if you're ever a camp nurse, you got to ask the kids to see it, because they come and they've got belly pains because they're homesick, and then they tell you they have diarrhea, and they're not having diarrhea, they just want to go home. One of the worst jobs I've ever had. Anyway, neurological, denies headaches, syncope, which is that room spinning, dizziness, numbness, tingling of extremities, paralysis, meaning they can't move a part of their body, or paresia, which is muscle weakness. Endocrine denies history of elevated blood sugars, denies sweating, heat, cold intolerance, thinning hair, dry, brittle skin, hair, or nails. When someone has heat or cold intolerance, they have sweating going on, thinning hair, dry, brittle skin or nails. You have to think about thyroid, something being off on their thyroid. And the other thing with thyroid can be they get very depressed because it has to do with your mood as well. GI, GU, for this patient I deferred it because obviously her cardiac is more of a concern right now, but you want to know if you do this system on people, you know, about urination, what color the urine was, you know, and stuff, if they're voiding on their own, if they need, you know, a bedpan, or do they need a bedside commode, or what they're doing. And GYN, this is the area where you would get a thorough GYN OB history from a woman. So you would include like last menstrual period here, or you could put that under past medical history for last menstrual period if you want. Either place it can go. How many pregnancies. So when we document pregnancies, we do it gravida, which is the number of pregnancies, para, which is the number of live pregnancies that they delivered. Gravida, para, and abortions are here. And this can be actual abortions where they go to a clinic, or it can be a spontaneous abortion where they just miscarried the baby. When you miscarry, that's considered a non-surgical abortion. So you want to know all those things. And you can also go into more detail about their period, like how heavy their bleeding is, are they regular, are they on birth control, can go in here, are they taking like the birth control pill, they have a patch, diaphragm, what are they using, that all can go in here. All right. In the ER, I will tell you that we ask, is there any chance, we ask about last menstrual period, and then we ask, is there any chance that you can be pregnant, and we run the pregnancy test anyway. And the reason we do is a lot of women don't know that they're pregnant, or don't want to admit that they're pregnant, and obviously that may have some bearing about why they came to the hospital to start with, but in the long run, we're going to end up giving them medications, and we don't want to give a medication where that might be tetragenic to the developing fetus, and then have them come back and sue us because we did. I worked briefly in an urgent care in Wayne, and this patient came in, was well known to that practice, so the girls that checked her in knew her or whatever, and the young woman came back, and I ended up giving her an antibiotic which had potential tetragenic qualities for the fetus, and the pharmacist caught it and called and whatever. And so I ended up reordering something that wasn't tetragenic, and I felt horrible. And it turns out the staff all knew she was pregnant, but they didn't put it in the medical record. And so I had no way of knowing. And the attending doctor that owned the practice there, I was so upset. She goes, look, she goes, normally it would be upsetting, she said, but I don't blame you. She said, but honestly, this young woman, I know the family situation. She lives with her grandmother, and she's planning on aborting this baby. So she goes, I changed the medicine. She said, so don't worry about it. And I said, okay. So we averted a crisis, but we need to know if they're pregnant because we are ordering stuff that can be really bad. Musculoskeletal, they deny musculoskeletal pain, denies problems with mobility, denies history of trauma or injury. Maybe they have arthritis. Maybe they've had a previous stroke, and we would put, you know, that they're unable to move, or they have had a stroke and their hand is in a contracture, which means that it's kind of frozen in one position. You know, we put that they have a right-sided or left-sided contracture of the left or right arm. Integumentary skin, hair, and nails. This person denies rashes, lesions, or any skin breakdown. And the very last one is psychosocial. Denies depression, anxiety, insomnia, denies change in appetite, denies suicidal thoughts or ideations, homicidal thought or ideations. So anybody that tells you that they're having suicidal thoughts and planning on harming themselves or thinking about harming themselves, you have to document here whether they are or not. And if you work in a psych hospital or on a psych ward at any time in the future, you'll go a step farther and you ask them if they can contract for safety. If they can't, they will have to have one-to-one observation. If they can contract for safety, everybody on a psych ward gets 15-minute checks where you check to see where they are and what they're doing every 15 minutes. But I will tell you, if someone's intent on hurting themselves, they will find a way. If there's a will, there's a way. So even if you're a best friend to someone that has hurt themselves or attempted, even if you were, like within 6 feet of them and tried to watch them, like this all the time, they can do it. They really look around and they figure it out. I was working in a psych hospital down in Virginia, and it was on an unlocked psych floor, but the building was locked. You got buzzed in from the lobby. And we had a woman that was there for sexual trauma issues, and she dissociated back to childhood. And in that, she, very sneaky, remembered that when she went through the cafeteria line, the kitchen staff would have the back kitchen door propped open with a wooden thing like we do with this door. And she went out through the kitchen door. And we had to notify the police because she was gone. And the police ended up bringing her back. They found her down on Virginia Beach, just sitting on the sand. Thankfully, she hadn't done anything to herself. But I got in really big trouble because I was the charge nurse. Even though we were doing 15-minute checks, I still got in trouble. And it was the MA that kind of had stopped doing a couple of checks and stuff, but didn't tell me, but I was the one that got in trouble. So anyway, it only takes a second. So, and then we want to know if there's a history of hospitalization for mental health issues, history or treatment for substance abuse. We need to know that. And that's the end of the subjective part of your note. So this is actually the first part. Then you would add what we did last week. As you can see on the bottom, the very first is the vital signs, which is blood pressure, heart rate, respiratory rate, your O2 sat. This lady's on 2 liters a minute, LPM, by NC, nasal cannula. The temp, how tall she is, how much she weighs, and what her BMI is. All right, any BMI 30 or above is considered slightly obese. I once had somebody had a BMI actually of 22. She's really a thin young woman. Don't know how he did it, but probably didn't eat anything.
So with this review of the systems, we do all of their subjective info, and then do we put the info last week in the same spot?
Yeah, you do it on the second part of the note. It all goes together.
Yeah,
So it's one continuous note.
it's like what we did last week.
Okay. Now, most of you are going to be using electronic health record where you have a digital signature that you sign in. But if you ever do a paper note, the correct way to do your signature now is this. It would be S for Susan, okay? Bushinsky. No extra K, that Elsevier likes to add in. And then I'm an RN. But for you guys, you would be a student nurse. And then your affiliation is EMU. And the date, you always date. So 9/16. You don't put your whole first name, just your first initial. And if they ever have to go back and check to see if you did something or didn't do something in your note, they will look and they will basically see that you're EMU affiliated, and they will contact the school's director. You know, if there's a problem, if you've done something wrong. You always tend to hear about wrong things versus pats on the back of right things, but they will contact the school director, but that's how they know that you're EMU. Okay, I'm gonna take this off.